Welcome to Pediatric Case Review. Today's lecture is a comprehensive, case-based review of coarctation of the aorta, designed for general pediatricians. We will work through 12 cases, covering the collapsed neonate, the forelimb examination, the physiology of the closing duct, differential cyanosis, the chest radiograph, echocardiography, the bicuspid valve, emergency management, the oxygen trap, definitive repair, life after repair, and the teenager whose diagnosis was missed. Let us begin. Question 1. An 8-day-old term boy, discharged well at 36 hours after a normal newborn examination, is brought in mottled and lethargic after refusing 2 feeds. Heart rate 178, respiratory rate 62, capillary refill 5 seconds. The right brachial pulse is easily felt. Both femoral pulses are impalpable, and the liver is 3 centimeters below the costal margin. The pH is 7.14 and the lactate 8.6. Which is the most likely diagnosis? Option A, late onset group B streptococcal sepsis. Option B, coarctation of the aorta. Option C, congenital adrenal hyperplasia with a salt-losing crisis. Option D, supraventricular tachycardia. 4 findings decide this case. Well at the newborn check, then collapse in the 2nd week. A brachial pulse that is easy to feel, 2 femoral pulses that cannot be felt at all, and a large liver from a heart failing against obstruction. The correct answer is option B, coarctation of the aorta. Collapse in the 2nd week of life, the very window in which the duct finishes closing, is the classic timing of a duct-dependent obstruction. The duct was masking the narrowing, and the newborn examination was genuinely normal while it stayed open. Weak or absent femoral pulses in a collapsed neonate is the finding that makes the diagnosis. Sepsis, an adrenal crisis, and a tachyarrhythmia can all collapse a baby, but none of them abolishes the femoral pulses while sparing the brachial. Question 2. A 6-year-old girl is referred after a raised blood pressure at a routine check. She is well and plays sport without limitation. Right arm pressure is 128/78 with an appropriate cuff. Femoral pulses are present but feel late against the right brachial, and a soft systolic murmur is audible between the shoulder blades. Which bedside measurement best supports the diagnosis? Option A, a 24-hour ambulatory blood pressure recording. Option B, blood pressure in both arms and nothing else. Option C, repeating the right arm reading with a larger cuff. Option D, a systolic gradient of more than 20 millimeters of mercury between arm and leg. 4 findings decide this case. 1 limb has been measured, and the lesion sits between 2 territories. Brachiofemoral delay, the femoral late against the right brachial. A murmur between the shoulder blades over the descending aorta, and whatever is chosen must be possible in clinic within minutes. The correct answer is option D, a systolic gradient of more than 20 millimeters of mercury between arm and leg. The obstruction lies between the arm vessels and the leg vessels, so the measurement must compare the 2 sides of it, and a difference above 20 is significant. Both arms sit above the lesion, so comparing them can look normal. Ambulatory monitoring and cuff changes refine the hypertension, but say nothing about where the obstruction lies. 4 limbs, not 2, and size the cuff to the limb, because an arm cuff on a calf hides the gradient. Question 3. A 7-day-old term infant is admitted in shock. Echocardiography confirms a discrete narrowing of the aorta immediately beyond the left subclavian artery, with a ductus arteriosus that has almost closed. His parents say he was entirely well at home for the first 6 days, and they ask how a narrowing present since before birth caused no trouble at all until this week. What best explains the delay? Option A, the lower body was being supplied through the duct. Option B, the narrowing has progressed rapidly over the past week. Option C, the left ventricle has only now begun to fail. Option D, pulmonary vascular resistance has fallen, unmasking the lesion. 4 findings decide this case. Something open at birth has been closing over the past week. The narrowing sits exactly opposite where the duct joins the aorta. A route existed by which blood reached the legs without passing the narrowing, and the shelf itself has not changed. Something else has. The correct answer is option A. The lower body was being supplied through the duct. The coarctation sits opposite the duct's junction with the aorta, so while the duct stayed open, blood reached the legs through it. When it closes, the bypass disappears, and constriction of ductal tissue in the aortic wall tightens the narrowing further, so the left ventricle must suddenly pump the whole lower body across the obstruction. Ventricular failure is the consequence, not the cause, and falling pulmonary resistance unmasks left-to-right shunts, not aortic obstruction. The duct was doing the work. Question 4. A 3-day-old term newborn is assessed before discharge. He is feeding well, the chest is clear, and there's no murmur. Preductal saturation at the right hand is 96%. Postductal saturation at the right foot is 82%. Both traces are good, and both probes have been repositioned. Femoral pulses are present, but weaker than the right brachial. What does this saturation pattern describe? Option A, reverse differential cyanosis. Option B, peripheral cyanosis from a cold foot. Option C, differential cyanosis. Option D, probe artifact from a poor trace. 4 findings decide this case. The lower reading belongs to the postductal limb. The hand reads higher than the foot, the usual direction exaggerated. The duct is supplying the lower body with less well-oxygenated blood, and the weaker femorals point to the same territory. The correct answer is option C, differential cyanosis. Blood reaching the lower body through the duct is less well-oxygenated than blood reaching the head and right arm, so the hand reads higher than the foot, a 14-point gradient, which is pathological. This is the opposite of transposition, where the foot reads higher. The direction of the gradient names the physiology. A cold foot lowers perfusion, not saturation, on a good trace, and artifact was excluded by repositioning both probes. This is exactly why routine screening measures hand and foot. Question 5. A 12-year-old boy is investigated for hypertension found at a school medical. Right arm pressure, 152/88. Femoral pulses weak and delayed. A chest radiograph is requested, and his mother asks whether the same film would have shown the problem when he was a baby, since he had a chest film at 3 weeks of age. Which statement about the chest radiograph is correct? Option A, it would have shown the same changes in the newborn period. Option B, rib notching appears only in older children. Option C, notching affects the first and second ribs before the others. Option D, a normal film at 12 years excludes the diagnosis. 4 findings decide this case. The notches are cut by vessels that have had to enlarge. Enlargement of collaterals takes years, not weeks. The first 2 ribs arteries arise above the obstruction and are spared. And no chest film is good enough to exclude this diagnosis. The correct answer is option B. Rib notching appears only in older children. The notches are cut by enlarged intercostal collateral vessels carrying blood around the obstruction, and those vessels take years to grow. The newborn film shows a big heart and congestion, nothing specific. The first and second intercostal arteries arise from the costocervical trunk above the obstruction, so their ribs are spared. Notching involves ribs 3 to 8 on both sides, and a normal film never excludes the diagnosis. The femoral pulses remain the test. The other classic sign is the figure of 3, dilated segments bulging above and below with the coarctation as the waist. Question 6. A 9-day-old infant is stabilized on prostaglandin after presenting in shock with impalpable femoral pulses. He is now well perfused with a normal lactate. A standard parasternal echocardiographic study has been reported as showing normal ventricular function and no septal defect, and the cardiac center asks for further imaging before transfer. Which investigation should be done next? Option A, echocardiography with a full arch view. Option B, computed tomography angiography of the aorta. Option C, cardiac catheterization with pressure measurement. Option D, magnetic resonance angiography of the aorta. 4 findings decide this case. The study already done looked at the heart, and the lesion is not in the heart. The arch must be imaged along its whole length. 1 of these can be repeated at the cot side in minutes, and 3 of these require a journey a stable baby on prostaglandin does not need. The correct answer is option A, echocardiography with a full arch view. From the suprasternal window, the whole arch comes into view, the narrowing and the flow across it, and ventricular function has already been assessed from the standard windows. The first study was not wrong, only incomplete. A parasternal study can miss the arch entirely. The suprasternal view is repeatable at the cot side without moving a prostaglandin-dependent baby. Computed tomography, magnetic resonance, and catheterization all have their places. Planning, follow-up, intervention, but not in making this diagnosis now. Question 7. A 4-year-old girl had a coarctation repaired in the neonatal period. At review, she is well and normotensive with no gradient. An early systolic click is audible at the upper right sternal border, followed by a soft ejection systolic murmur. Her height tracks the 9th percentile. Her mother mentions she was a small baby, and a karyotype has been requested. Which associated lesion is most likely? Option A, atrial septal defect. Option B, persistent left superior vena cava. Option C, mitral valve prolapse. Option D, bicuspid aortic valve. 4 findings decide this case. An early systolic click at the upper right sternal border. The valve that sits immediately upstream of the repair. A karyotype sent for a separate reason, short stature in a girl. And the repaired coarctation itself is behaving perfectly. The correct answer is option D, bicuspid aortic valve. It is the commonest lesion found alongside coarctation, present in half or more of cases, and the early systolic click is the sound of its 2 cusps opening as a single slit, a click that radiates widely and does not vary with respiration. A septal defect would murmur differently. A left superior cava makes no sound at all, and mitral prolapse clicks in mid-systole with a late systolic murmur. And every girl diagnosed with coarctation should have a karyotype because of the association with Turner syndrome. Her stature is the visible clue. Question 8. A 9-day-old term infant arrives gray and mottled, saturation 88%, heart rate 190, capillary refill 5 seconds, femoral pulses impalpable, liver 4 centimeters down. He has already received 20 milliliters per kilogram of saline with no improvement, and cultures have been taken. The pH is 7.09 and the lactate 9.4. What is the single most important next step? Option A, a further 20 milliliter per kilogram fluid bolus. Option B, intubate and ventilate in 100% oxygen. Option C, start an intravenous prostaglandin E1 infusion. Option D, start intravenous antibiotics and await cultures. 4 findings decide this case. Fluid has been given and has not worked. Impalpable femorals name the obstruction. What kept his legs perfused has been closing over the past week, and only one option changes the next hour. The correct answer